Hi everyone, this is Morgan from the New England QIN-QIO, and we're going to get started for our webinar today. Please do mute your lines because we can still hear some background noise. We greatly appreciate it. I want to thank you all for joining us for today's Interact webinar on communication tools, part 2, and process mapping, with Carol Dietz and Sheila Eckenrode. Before we get started, I want to review a few housekeeping items. This call will be recorded for training purposes, and I'll provide you with details on accessing that at the end of the webinar. We tried to put the phone lines on mute, but again, if you guys can mute yourselves as an additional backup, we would appreciate it. And also do not put us on hold because we will hear your hold music. We are going to be taking questions at the end, and I'll give you instructions on how to unmute your line at that time. So I'll now pass it over to Carol to get us started.
Good afternoon, everyone, and welcome to our 6th session of the Interact webinar training series. I'd like to welcome all the nursing homes that are joining us this afternoon. As Morgan mentioned, I am Carol Dietz, and I'm one of the quality consultants from the New England QIN-QIO, state of Connecticut, and the moderator for this session. I'm here with Sheila Eckenrode, who will be doing the heavy lifting for this afternoon, who will be giving the presentation on the communication tools as well as process mapping. But before we get started, I want to reiterate just what Morgan has stated. Please put us on mute. Last month, we had several callers who we could hear several conversations going on in the background. Someone also put us on hold, so we heard the music from your facility, and it's very, very distracting and unprofessional. So please look at your phone and put us on mute so we can have a wonderful session, because this is a very important session involving the Interact tools. So thank you so much for understanding. So moving on. So the objectives of today, I have already welcomed everyone. Sheila will be reviewing the SBAR tool again, but in much more detail, since this communication tool is the linchpin to all the communications between the nursing home and the physician, the nursing home and EMS, and the nursing home and the hospital. So the SBAR tool is something that we really want you to start using on a daily basis and make it part of your work. So whenever you're talking about an acute change in a resident in your facility, you're automatically thinking SBAR. Also, Sheila will be reviewing the nursing home transfer form and the acute care transfer checklist, which is part of this new acute care transfer process that we're implementing to ensure that all the right communications get to the right place at the right time for the resident, so making that transition as safe as possible. And finally, Sheila will be diving into the process mapping and why it's so important when you are starting a new process and initiating a new intervention. You need to map out what you're presently doing and where you want to go, so you can look at your gaps and then also bring the right people in to ensure that the process goes smoothly. At the end of the training session, we will have a state-specific discussion on the content of today's webinar, and I will have further information for each of the states at the end of the training. As I do every month, I want to make sure that I include all our sister states, because this is a regional training. So Connecticut, it's Florence and Sheila and myself as the care transition leads for the state. In Rhode Island, it's Kathy Calandra, Amelia Odom. In New Hampshire, it's Joyce Johnson and Margaret Crowley. Vermont, it's Kessler and Gail Harbor. Massachusetts, it's Lynn Chase, Cheryl Leary, and Lori Neerbaum. And in Maine, it's Maureen Leary. So again, welcome all the nursing homes from all our 6 states. And now I'd like to turn it over to Sheila Eckenrode for this afternoon's presentation.
Welcome back, Interact partners. We're glad that you're here.
Today I'm going to talk to you a little bit about communication tools across the continuum of care. And as Carol and Morgan both mentioned, process mapping as a way of designing an implementation plan for new policies, procedures, and processes in your facility. Just a quick word about communication tools. We know that 80% of medical errors occur because of miscommunication between providers, and that's a stat from JCHO, and you know that they're measuring that, so they must be right. And due to that, there are two strongest recommendations for reducing medical errors and increasing patient safety are to standardize the communication process whenever possible, and to hardwire processes dealing with communication. So you do the same thing over and over again and have some way of being prompted to do the right thing. So before I dive into that, again, I want to thank you for being here and thank you for your participation up until this point and ask you for a favor, if you can bear with us. I have a couple of polling questions that recur during every session. The reason for that is being a quality improvement organization, we want to measure progress and we want to measure penetration of Interact. So just as if I said to you, I've lost some weight, you would say, how much? And if I said, I have no idea, you probably wouldn't believe I was really doing that well. So CMS will say to us, when we say to them, we're implementing Interact here in Connecticut, they're going to say, how do you know that? How far has it gone? How many people have been touched by that? So if I could ask you to answer this polling question, and please tell the truth. We're not going to track you down and you're not going to get a bad grade, but has your facility started inputting data into one of these tools, Advancing Excellence, the Interact Admission Tracking Tool on a computer, Interact the Admission Tracking Tool using paper, your own facility-based or corporate-based tracking tool, or you have not started tracking the admission data yet. So if you could take a minute to answer that, I'd be so grateful.
Emily, can we open this first polling question, please? Emily, are you there? There we go.
Thanks for your patience with this. Just to give some feedback, we are finding every time we ask this question, more people have begun tracking readmissions here in the state of Connecticut. More of our participants are using the tool, so we're making some progress.
Don't forget to hit the submit button at the bottom of the form to make sure that your answers are included. And there are the results. So if you look,
okay. Getting somewhere. Thank you for that. Another question. Sorry to put you through this one more time, but our second polling question. With the SR tool, have you implemented the SR tool in your facility, yes or no? And while you answer that, I'll just mention that we will review that tool again in greater detail today, because it's really a really good way of monitoring changes in resident condition as well as preventions for changes in resident condition. You answer that question and hit the submit button. That'd be great.
Alrighty, so we should have our answer in just a minute, but once again, if you'll mute your line for us, we're hearing a little bit of feedback. Thanks.
All right, thank you. And one last polling question. Stop and watch tool in your facility.
I think I got it.
You got it. Yes or no, and hit the submit button. Thank you so much for that. Again, thank you for answering these questions, and the results will be available to you all. But as I said, over the weeks, we're finding that more and more people are implementing these tools or getting started with interactiveness. That's a very good thing. And someday we'll all be on the same page in the same place.
So we got the answer.
All right, thank you. So, communication tools. Today we're going to talk about communication tools that can be used between levels of care. And again, I want to stress that the passage of a resident from one level of care to the next is a dangerous one. In fact, I think residents and families knew just how dangerous it is. They would probably cling to us and beg not to be sent. So the communication tool that Interact provides us with, SBAR, situation background, assessment or appearance, and review and notify our recommendations. The Interact version 4 has changed the SBAR so LPNs can use it. So they've taken the word assessment out of it, so your LPNs, your staff LPNs can use this to document what they see, the patient's vital signs, the conversations they have with other providers. The nursing home transfer form, which includes host status, goals of care, functional status, what needs to happen to the residents to return back, contact information, who you can talk to at the nursing home. We all know that it's futile to give somebody a main number. They'll never connect with the person who actually sends the patient out or the resident out. Capabilities list, we've talked about that too, and all of these are available on the website, so take some time with your team to review them. What can the nursing home do? Can you do IVs or not? And you want to make sure that the ED knows these things where they develop a treatment plan for your residents. And the acute care transfer checklist, which just lets the receiving clinician know what's inside the envelope that you sent the patient in. All right, SBAR communication form. So we had talked about this a little bit in the past, but I'm going to zoom it in with the help of my friend working here so we can really take a hard look at this form. All right, so what do we got here? It's, you know, as any form looks at first glance, it looks like it's too long, the print's too small, there's too many boxes. So I want to break this down a little bit so when you go to show it to your staff members, you can explain it in the same way. So what are we really asking staff to document here? The situation, change of condition. What happened? When did it start? It's getting worse or it's getting better? Things that make it worse, things that make it better. Is this something that's occurred before? What worked in the past? Pretty easy. I think that most of our nurses will be able to do that. A little bit about the resident. Are they here for long-term care, post-acute? Medication alerts, that's great. If the transfer nurse knows that they're going to change the medication, something received, something added, set of vital signs, pulse ox, blood sugar. Nothing too tough so far. And the resident's name. So that's that first page. That's the essential information that this form is prompting you to give before a resident leaves. Now, the second dreaded, hated, and feared part of this form is the second page, and I want to talk a little bit about this. The second page is really a review of systems and a more complete physical. But it says again and again through the prompts that if this isn't pertinent to the reason you're sending the resident to the ED, you don't have to fill it out. Nurses love to fill things out. You know, you give us a blank space and we're going to fill it full of information. If there's a box, we got to check it. We can't walk by these things. So I encourage you to go through this form with your staff and look at this. You know, mental status evaluation. You're just asked if there's a change. No change? No change. Functional status. Is anything different? You're not asked to, walk the patient, see if they're independent with ADLs, look up their usual functional status. Is there a change or no change? This is an acute change in resident condition form. Behavioral evaluation, is there a risk there? Or just check the box. It has nothing to do with why you're sending the resident. The resident fell, the resident's short of breath, nothing there. Respiratory evaluation, you can do a good set of lung sounds and you can do a good chest evaluation, or you can just say, it doesn't matter. You can get not clinically applicable with or X-ray intervention. And the same with GI evaluation, which, you know, if you're sending someone to the ED with shortness of breath, you don't need to know when they have their last bottle. So there we are. We got through that whole evaluation, and it wasn't as bad as you thought it was. The same for urine, GU, skin evaluation, pain. Again, you're only filling these out if they're pertinent to the reason the resident is being sent to the ED. This is emergent communication. It should be streamlined. All right. It's the phone. Now, appearance or assessment. And the verbiage on this says appearance of LPNs can use this form. So don't have LPNs recording their instructions and their recommendations on one form and then asking an RN to duplicate that. So your LPN can fill this out first time around. They can talk about what they see, what they think is happening, and then who they notified. The primary clinician, APRN, and here we have a section where we can talk about what was done, all right, or what's being ordered. So I have a change in resident condition. I go in, I assess the patient. I fill out the pertinent information. I call the APRN. He says to me, okay, let's get some blood work. Let's get an X-ray, all right? He says, let's transfer things to the hospital. So we've got that captured, and some brief paper notes, whether or not you tell the family, that's important. I know that DPH is going to look for that time. So that's the SR, the transfer, and it's not as it first looks, and I hope you agree with me. The second communication form is the nursing home transfer form. That's me. All right. This also looks much more intimidating than it actually is. The resident's name, where we sent them, who sent them, who to call with questions, who their primary care clinician is, contact person, code status. I think any clinician's going to be able to fill out that without too much ado. Key clinical information, diagnosis, COPD, vital signs, dementia. Usual mental status is so important for an ED because if they don't know what the patient's usual mental status is, they're going to start from the premise that this patient is acutely confused, and that's when they're going to start ordering some blood and some urines, and they might not be the things that you sent the patient there for, especially urines. I hear about that a lot. The usual functional status, let's the folks doing the ED ED evaluation, know if this patient was walking and now can't, and additional clinical information. Devices, precautions, allergies, all fair enough, not too hard. Risk alerts, they should be on the card or whatever you're using for your nursing care plans. I'm sure you track risks like falls and elopement risks. Personal belongings set with the resident, that would be awesome, because when they're lost, you can say, they're lost in your building, not mine. And very important, you'd be able to accept this resident back under what condition? If the ER determines that the treatment can be accomplished in the nursing home, if vital signs are stabilized, or what are your thoughts? And now, again, the dreaded and most hated second page. So let's break this one down. The second page is not necessary to transfer the resident. This is like the really good stuff to know if you want your resident to get good nursing care in the hospital. This doesn't have to be sent with the resident, sent later. And you can leave this blank, and you can just check out that your check box that you're going to send it later. The resident's social work are very important for transfer. Family issues, if the family is insisting that the resident come, let the ED know that. I've been talking a lot to ED personnel about how the nursing homes that, feel that they could treat the resident but are hearing from the family that they would be more comfortable with the resident in the hospital. They want to support you in that. They want to back you up, and they trust your judgment. So let people know. Let that be known. Behavioral issues. Okay. Primary goals at the time of transfer, that's kind of left over from the government side. If you can fill it out, fine. ADL, again, this is going to be good for your resident when they're in the hospital. It's going to help the staff there, help you, help them. Any impairments, if the person has a speech impediment, if they're hard of hearing, this is like stuff that you would want to know about a patient that you were about to receive in the hospital. And then that's it. So you're looking at just that first page. It's an emergency transfer. Second page can be faxed over later if the resident is admitted. It helps the nursing staff care for the resident in a good way. Talk about these communication tools, and I hope that in that review you can see they're just not as bad as they look at the first glance. Okay, so what do we do once we get these filled out to the best of our ability? And again, we're talking about the best of your ability. We're designing a process for the majority of transfers, not for the exceptions. And I think in healthcare we often want to talk about the exception. I can't fill this out if my patient's being intubated. That's true, but you probably can fill it out if your patient's being sent to the ED for an acute change in mental status, a fever, worsening shortness of breath, falls, need for x-ray, lots of the reasons that generally we send folks out for. So you're going to put all this stuff in an envelope. And if you live in Connecticut, that envelope's going to be red. And the folks that transport your patients in EMS and the clinicians that receive your patients at Yale and Hartford and Bristol and Middlesex and all sorts of hospitals out there in St. Francis are going to be looking at that red. That's going to be a signal to clinicians that this is where the important information, the important nursing assessment, and communication from the nursing home resides. So we're moving towards that. Here in Connecticut, that envelope will be red. But your EMS folks are going to need the same information. So we'll talk about that in a little bit. But in addition to the SBAR communication form, the nursing home transfer information, you know that the ED clinicians and the EMS folks are going to need a copy of your most recent medication list, the patient state sheet, patient and next of kin, and DNR orders. Absolutely. And I think for the most part, this is the kind of information that you're used to sending with your residents. So it won't be too much of a behavioral change for your staff. In addition to that, we are going to ask that you send a capabilities list, and that can be pre-printed, and it's already be in the envelope, so you don't even have to stuff that one in. And that's just letting the ED staff know what the nursing home is capable of. Can you do IVs? Can you push IV meds, that type of thing. And it could be pre-filled and reviewed and updated. On that outside of the envelope goes an interactive form called the Acute Care Transfer Checklist. This form just alerts the clinician as to what's in the envelope. So if something is missing on arrival to the emergency department, they know something is missing and then they can go look for it. So I'm going to go over that one more time. In the envelope, go into the emergency department. You're going to want the interact communication tools that we just talked about, the SBAR, the nursing home transfer list, the capabilities list, the med list or record, the resident face sheet, DNR orders. They really, really need them. And that information is going to be received and opened by the emergency department staff. Now, here in Connecticut, we've been working with our EMS providers as to what they need. And at this point, they say they pretty much need the same stuff. So in order to maintain the integrity of this process as intended, you really need two sets of documentation. So the EMS transport teams are asking for this same envelope, only it belongs to them, and it doesn't have to be right here in Connecticut. So I know that this is a challenge, and I'll be interested in hearing from people as to how they're supposed to make this new process work, and if we can share some tips. I know that making copies is difficult. I also know that your staff is probably making copies of things for transfers already. They probably have to make a copy of the MAR, they might have to make copies of other documents, labs, whatever. So somewhere embedded in this transfer process is that piece of making copies. So let's all put our heads together and figure out the best way to get this done. All right, so how to figure out the best way to get that done. One of the QI tools that we use a lot here at Qualidine is something called process mapping. And some of you might be very familiar with it, some of you might be somewhat familiar with it, and some of you might say, oh, this is something I've never heard of, and it might not be useful. But indulge me for a minute when I talk about it in terms of how it illuminates the process and how much you can learn by going through this exercise. That's just an exciting process that illustrates how a transaction happens. You're just step-by-step outlining what goes on. The visual representation, and that part of it's really important. The people who brought us process mapping and the people who teach it will tell you it's not enough to have someone record it. You've got to put it up on the wall. You've got to put it in a place where the team working on process mapping can see it. They can move steps around, or they can talk about steps that occur simultaneously. It should be detailed enough that it would allow someone unfamiliar with what's being done to understand what's happening. Not necessarily to do it, but to understand what's happening. So, make this clear to understand. This morning I decided I would process map eating up my cat. All right, so I get out the bowl and I put it on the counter. Or I have a decision to make, and in process mapping, decisions are always represented by a dime. And it's important that you grab that making point, because at that point you're going to have yes or no, or this way or that way, and it will become a whole new map. Because if there's yes or yes, it's going in one direction, if it's no, you're going in another direction. So it's important to capture those moments.
Hi, this is Carol. Could everyone please put yourselves on mute? We hear a lot of background noise right now. Thank you so much.
That's my task. So I open the door. I decide I put it up. Okay, so I'm going to go with the wet food. Yes. Now I got to find the piano. Have to got the counter, I take the cat off the counter and put it back on the floor. I open the can. The cat jumps back on the counter, I take the cat off the counter, put him back on the floor. Put the food in the bowl, place the bowl on the floor. Or I go with the dry food and I eliminate several steps. In doing this exercise, I can already see that if I lock the cat out of the kitchen, I've eliminated at least 2 steps. So that's what I learned about process mapping the feeding of my cat. So, how to chart an existing process. You want to get a group of people familiar with what's going on together. Use sticky notes, or you can draw boxes on a whiteboard, on the wall, etc. And start at the very beginning, step by step, what's happening. Remember the decision points, because they're going to push you in different directions. If the decision is yes, there's going to be a whole new set of steps. If the decision is no, that's how you really get a feel for how complicated a very document step by step what's going on. And as you do that with your team, you're looking for redundancies, you're looking for rework, but probably most that's not how it's done, or that's not how I do it, or you forgot a step, and your colleague might say, I forgot a step, I never knew I was supposed to do that. So a lot of variation in policy and procedure can be revealed by this exercise. Telling this, the process for assembling documentation for a transferred resident is very, very complex. And it's going to look more like that. And that might only be a small quarter of it. So, this is, again, just an example. I'm not even pretending to know how complex and all the steps that go. Say something like this. The residents assessed, we've gotten vital signs, called the supervisor, called the APRN, got the order, called the ambulance. This is really high level. Just want to break it down much lower. You go back, you will share the president, you document the assessment, report off to EMS, copy all your stuff, and assemble a documentation. Say that's an existing process. And again, I'm not even pretending that's real, because I don't know it's real, because I'm not there, and I haven't seen it done. All right, so you have your existing process, and now you know something about the new process. Everyone looked at it, and I would encourage you, if you have a team that's going to do that, that's going to match it out, leave it up on the wall. Leave it where other people can see it, because they might start adding steps that you didn't even know existed, or they might be crossing stuff out saying, we don't do that anymore. So let it sink in for all of your staff or with yourself. So now you want to move on to designing a new process. Same exercise. You're going to say, okay, let's walk through how it would look with Interact. What might be different? You want to document the results, leave it up on the wall for a while, let everyone have a good look at it, follow up, hear from your staff what worked and what didn't, and then regroup in a month or two after it's been used a few times. So maybe the new process might involve LPN assessing the resident and getting the vital signs on that SR while she's in the room, calling the supervisor, calling the APRN, taking that same SR form with her when she sits down to talk to the doctor, documenting on that, calling the ambulance, reassuring the resident, reporting, and again, copying the forms, which I know is going to be the thorniest part of this process. So, just something to think about is it's a great way to get people on board. It's a great way to learn just how complicated things can be when it comes to transfers, and it really helps us understand why so many medical errors happen at the point of handoff, how complicated it can be, and where we can improve. And that's it. Any questions so far?
If you have any questions, you can press *6 on your phone to unmute your line. Or if you've manually muted your own phone, go ahead and unmute to ask your question.
Okay, there's no questions thus far, but we'll talk more when Carol goes over our report out and we split up to our state group.
Thank you, Sheila. Thank you so much. This is Carol Dietz again. So, now you have a good idea as to how to design your new acute care transfer process. But you also have to think about, as Sheila says, you have to sort of drill down a little bit more. You're going to have to think about where are you going to put each of these new documents? Where are you going to store the SBAR form? Where are you going to store the transfer form? Who's going to put together those red envelopes with a checklist on it? It has to be assembled. So you need your team, as you're doing your process mapping, you have to work these areas out as you meet with your team. Also, one of the other things that you have to look at in each of your units are where is your copier for that unit? And also the supplies for the copier, like the paper and the toner, because during an acute care transfer is not the time to be hunting around your facility looking for some white paper to make copies on. Again, this is all pre-planning. It is the more you plan and the more you pre-plan, the smoother your transfer process is going to go. Also, as you're walking through this new process, this new mapping out of this process, you're going to assign team members to do the copying on each of the shifts. You're going to assign who's going to be getting the patient ready for the transfer, because that nurse is going to be on the phone with the physician, going to be talking with the nursing supervisor. Again, this nurse can't do the whole transfer by herself, his or herself. It takes a team. And so when an acute care transfer happens in your facility, it's like an alert goes off and everybody comes to help. And you should have roles assigned. It doesn't mean that one person is going to be the copier all the time, but as the acute care transfer is happening, you could say to the CNA of that unit, could you please make the copies for me? And she'll know, he or she will know exactly what copies need to be made, because the team, this has been part of the work of the unit, and is now, everyone knows what each of the roles are. So, again, this takes a lot of time, and that's why in Connecticut we're asking that the red envelopes, the EMS and emergency department envelopes, they don't get rolled out until the end of August. We're looking for a rollout date of August 30th. So because this is not going to happen overnight, you have to talk to your vendor about purchasing the red envelopes for Connecticut. Or just to make sure you do have the bigger envelopes in your facility if you're living in another state. And you want to make sure that you have enough of these other documents on hand and everyone in your facility understands how to fill them out. So again, that's going to take a good 2 to 3 weeks to in-service all your nurses on the SBAR tool, the transfer form, and the transfer checklist. You also want to make sure your leadership's involved and that they appreciate the whole process. So if you could get them to be part of your team as you're mapping out the new process, they can help you with deciding whether your facility needs to buy a new copier or several new copiers if your facility is so large. Because again, EMS needs that documentation as well as the emergency department. This is not a one-man show. This is a true team effort when there is an acute care transfer in your facility. So with that last piece of discussion, are there any other questions or any questions at all? Does anyone want to talk about a challenge or a solution to a challenge that we've heard today?
Hello.
Hi.
Hi, this is Portland here.
Hi. What can we do
How
for
are
you?
you?
Good, very good.
Good. I'm sorry, we had a little difficulty hooking up at the beginning of the session, and my only question is, I don't know if we missed it. Is this in place of the W-10, and is this happening at the August 30th target date or already in process?
So, that's a great question, and for those other states other than Connecticut, what she was referring to is the W-10, which is a form that has been in place now since 1987, that DPH and or DSS put in place to fulfill the public code obligation in Connecticut. There are certain data elements that must be transferred with the patient when there's an acute care transfer. So this form was developed, hasn't been touched in, 25 years? And so this, in Connecticut, this new process, when you have the face sheet, when you have the transfer form, when you have the SBAR form, when you have the medication list, then yes, the W-10 is not needed. We are moving away from the W-10. Does that answer your question?
Yes, so we should start that implementation, and is there a target date?
Yes, the target date is August 30th.
Okay.
But you can start now. We're ready for you. We're ready for you, Bridget.
Yep, as long as you have the process in place.
We're ready for you.
Are there any other questions?
Can I just ask, this is Courtney from Arden House.
Sure.
Just wanted to know, my director of nursing is here too, Mary Ellen. She wanted to know in regards to going to a doctor's appointment or anything like that, do you do the SBAR there? Do you do a W-10? How does that work? Just a transfer form.
Yes, just the transfer form and the copy of the face sheet will replace the W-10.
Okay.
And again, you're going to be providing much more information, and also the medication list. You always have to send the medication list. You're sending much more information if you are using the transfer form appropriately, filling it out appropriately. Now, for a non-acute transfer, that's going to be the front and the page 1 and page 2. But again, what we have been told by the emergency departments who have been receiving the transfer form and the SBAR form, they are thrilled with this information. It's like they now feel they have so much better control of taking over the care now of this patient. So thank you for that question. It's a great question. And again, that's Connecticut only because, again, we're talking about the W-10. I apologize about that for the other states. So we have a few minutes left. Are there any other questions?
Hi.
Hi.
Hi. I have one more question with the transfer form replacing the W-10.
Sure.
We talked at Yale about we're not doing that until we receive confirmation from the state, and there was supposed to be a blast package from the state.
Oh, boy.
Yes, and we have been in conversations with both DSS, and DTH, and they say as long as you have those data elements in your documentation, that's fulfilling the public health code in Connecticut. Neither one of them have said that they developed the form, so neither one of those agencies have stated that they can get rid of a form. But as long as you have those data elements, you are covered. You're covering yourself from the public health code.
Yeah, you won't be cited by DPH as long as you're using a transfer form and an SBAR.
And the face
sheet, of course.
I think that we need that needs to be clarified. We all need to hear from the state. The state tells us we have to use the W-10. I want to hear from the state. I don't have to use the W-10 anymore.
Okay, do you remember when someone from the state said you did have to use the W-10?
It's the State of Connecticut Department of Social Service Health Services form.
It is, but all that's required are those data elements, not the form.
Well, we can talk about this
We'll do that, yeah.
in the last 15 minutes of state-specific.
Yep. We'll get it done.
Yeah. So,
I know.
the question.
We have another.
Hi, can I ask another question?
Absolutely.
Hi, Portland here again, sorry. I'm just thinking because I have developed packets just like this, using the W-10. But there's also that form of transfer or discharge of notification that has to go with them. Are you including that in that package? The right to appeal, transfer, or discharge, and a copy goes to the next of kin?
Oh, I don't, Richard, I don't know. Are you talking about like a change in Medicare level of service? You shouldn't need to send that to somebody who's just going to the ED for evaluation.
I think it has to do with a bed hold and notifying them of their rights for a bed hold and the hospital receiving. I think it is mostly for Medicaid. I believe that form was originally, but it has to go with them when they go to the hospital.
Richard, let me do some research on that. That's the first I've heard of that, and that's the first time. I mean, I got to tell you that
I think transfer/discharge.
Okay, I'll research that for you, Bridget, and we'll address it at the next, Connecticut session. Okay?
Okay, great.
Thank you.
All right, are there any other questions?
Yes, hello.
Hi.
Hi, this is Sue from St. Patrick's Manor in Birmingham, Mass. Hi.
Okay.
We have modification what we've been doing here with policy and procedure in regards to the SBAR. So as we've all been taught, the SBAR is a tool to help prevent hospitalizations in order to improve communication between nurse and physician and nurse and family member to prevent that so-called return to the hospital. But in some cases, of course, we have to do so. In addition to our modification, what we have done in our policy and procedure that we've done a step forward, and some others have also, in regards to the SBAR. When that resident patient has a change of condition, when they have that change, a significant change of condition, elevated temp, breath sounds, labs, increase in Lasix, CHF workup, the list goes on and on. At that very point in time, our nurses make out the SBAR then. So therefore, we're preparing in regards to Dr. Day, in regards to communication to the physician, and in preparing to maybe prevent that hospitalization down.
Excellent. That's an excellent process.
Oh,
Thank
good.
you. That is best practice. That's exactly, those nurses should have those forms available, and whenever they're assessing a patient for a change of condition, that's exactly what they should be doing, is starting that form. Excellent.
Thank you very much.
Oh, no, thank you. Thank you for sharing.
I have a question. This is Debbie from Marshall's in Machias, Maine.
Hi.
Hi. My question is, what have you been seeing as far as the return information back from the hospitals? Are the hospitals on board with this Interact 4?
That's where we're going.
Oh, that's where we're going.
Yeah, that's where we're going.
In Connecticut, we have reached out to our emergency department stakeholders as well as our EMS agencies within the 3 communities that we're working with to talk about this new process. So our recommendation is, before you roll out your envelope, whether it's red or white or orange, if you're in a different state, you need to sit down with your EMS partners and let them know that this is your new process, why it's so important that they don't open that envelope that says it's going to the emergency department. And you should also be just notifying your your hospital contact, whether it's your community leader that you're working with, that's part of the hospital system, to let them know that you're ready to roll out this new acute care transfer process. Show them the envelope, show them what the documents are, what information's on the document, so everyone is aware that this process is going to happen, and pick a date. In Connecticut, we're picking August 30th as our rollout date. You may pick September 30th, because not only do you have to prepare your facility, but you'll then also have to reach out to your stakeholders to make sure that they are aware of this new process. So again, each state is going to be a little different. Each facility, again, you have to build this process, map it out, because there's a lot of different moving parts, and you want to make sure they're all in place before you roll it out.
Thank you.
You're very welcome. Excellent question. Thank you. So we're at 10 of, and just wanted to let you know that if you have missed any of the webinars that we've started back in February, you can now watch them, hear them, and pull the presentations down by going on the New England QIN-QIO website, and I have it posted there on the screen. It's www.healthcarefornewengland, all one word, .org. You're going to click on the events, scroll down to previous events. You're going to find your webinar, the one that you're looking for. You're going to click on that recording link, and before you actually get to the recording, you have to put in a few bits of information like your name, your facility name, what state you're from, and then your email address, and then you hit download, and then you can get the presentation, the transcript, as well as the recording. So that is available for you on the New England QIN-QIO website. And finally, if you do have any questions at all about Interact, you can reach out to any one of us, Florence, Sheila, or myself, and if we can't answer it, we will get to the answers. So that's what we quality improvement consultants are all about. So without further ado, we're going to be going into our state specific, and Morgan has some information for you.
So as you guys close out of the webinar today, the evaluation for today's session will automatically pop up on your screen. If you could please fill that out, we'd really appreciate it. If you don't have time to do it today, or you're sharing a computer with someone else, you will receive an email tomorrow with a link to the evaluation, as well as the link to today's events page. The PowerPoint presentation is currently posted on the website, but within the next few business days, we will add the transcript and recording for the webinar. As Carol said, you can download both of those. Please make sure to mark your calendars for our next Interact meeting. That's going to be on August 26th from 1 to 2, covering Advanced Care Planning Tool. So thank you guys, and Carol?
Okay, so for Connecticut nursing homes that are part of the participation, that have signed the participation agreement, please stay on the line. All the other states can jump off. New Hampshire, Joyce Johnson will be opening up a phone line for you, and you have the phone number there. It's 1-888-450-5996, and the passcode is 275687. So New Hampshire, if you want to jump on to talk with Joyce, if you have any questions, she will be available for the next 10 minutes. But for all the other states, thank you so much for joining us. Had some great questions. And again, we'll see you next month on August 26th. But Connecticut, your nursing homes, please stay on the line. We're just going to leave up this phone number for about a minute, and then we're going to jump right back on. So stay where you are. Okay, Connecticut nursing homes, I hope everybody's still on. And so for the next 9 minutes, we're going to be reviewing the homework from last month. We're going to discuss have any discussions about the content of today, and then we're also going to talk about next month's homework, which will really help you focus on process mapping out your current processes, moving on to your future process for the acute care transfer. So I just wanted to review this really quickly. Just want to remember, we talked about this last month about getting a participation certificate from from the New England QIN-QIO. You have a minimum, you have to watch at least 7 webinars. So that's why it's important to know that they are available on our website if you've missed a couple. And so not only do you have to participate in at least 7, you have to send us readmission data for at least 3 months. And so if you're on the Advancing Excellence and putting your data in there, you want to make sure you have sent us your data use agreement, so we can then pull your data. And if not, we're going to be sending you a readmission tracking email just so you can start putting your data in for us. So be on the lookout for that. And again, this is where the webinars are located. I had just talked about it, but you have it here on this slide. So, homework from last session, we didn't give any. Oh, it was great. It was a sharing call. We did a lot of sharing of best practices last month, as well as what were some of the challenges around the region, as well as some of the solutions that people had recommended. So, we're hoping that you have met with your Interact team, or it may have been your quality improvement team, to talk about what have you done so far, what's working, what's not working, and hopefully you have moved forward, and hopefully you are monitoring how things are working. Because if you put in a new process, you got to make sure it's working. So hopefully you are talking with your frontline staff, especially like with the stop and watch, to make sure that everyone is aware of how important these tools are. So, before I go into the homework for this month, does anyone have any questions or any best practices you want to share with your colleagues from around the state of Connecticut?
Any concerns or fears? I know I heard some concerns about letting go of the W-10 and some kind of pushback from the state.
And just to let you know, we have been, for the past 2 years, as a matter of fact, we have been talking with DPH, both at the hospital level, the nursing home level, and DSS, and they all say the form is not theirs. And they're only focused on the data elements, because that's in the public health code. I don't know if you've noticed, but many of the hospitals don't use W-10s anymore. All their data elements are now with the electronic EHRs. That was redundant, electronic EHR. With the EHR, their data elements are all embedded into their discharge forms. And again, they crosswalk the public health code with what they're using on their discharge forms to make sure that all those data elements are present. And we have also crosswalked the transfer form, and what's needed along with the transfer form is the face sheet, because it gives the patient's full name, the insurance information, as well as where they actually live if they're not living in the nursing home. That's why that face sheet is so important. Current MAR, and also the advanced directives.
I have one.
I'm surprised to see this. I'm sorry.
Go ahead.
I'm sorry. This is Meredith from Yale University. And I'm just wondering, I know this W-10 is a huge issue, but is there an expectation that the hospitals will give up the W-10, for example? Also, start using Interact? Yale New Haven has not. So that's why I'm asking.
Okay, because the Hospital Central Connecticut has, the state has. So that's why, but there is a transfer form from Interact from the hospital to the nursing home. So that's something that we can look into to work with the hospitals on.
Well, is that underway, or is that not anything that's being part of this rollout?
Meredith, are you talking about Yale New Haven Hospital?
Yes.
And the discharge summary that's printed off from the EHR?
There's Yale New Haven Hospital currently does the discharge summary and a W-10 for patients who are transferred who are going from a hospital to a skilled nursing facility.
And the W-10 is electronically generated?
I think it's partially populated through EHR, and then I think some manual instructions may be added in. I'm not the final authority on that, but I believe it's done.
Yeah, okay, well, we'll all move towards interact. I think what happens is that we're so, in our vernacular, we're so used to referring to any kind of transfer communication as a W-10 that no matter what we send out, it's called a W-10, and you might be actually sending out discharge summaries that are electronically populated, but have those, those, like Carol was saying, the data elements embedded in there. And I'm pretty sure that that's what Yale is sending out. But again, we've called it a W-10 for so long. I'm sure that when someone asks you to fill it out, they say, "Go get me a W-10," or "We're sending a W-10." The W-10 is just the name of that piece of paper. Am I being clear to you?
I think there's maybe an issue worth exploring, and it might be part of a concern in Connecticut. I mean, I'm only, in this case, speaking about Yale New Haven Hospital, but they definitely, the discharge summary and the W-10 at Yale are not one and the same, and in fact, they arise to facilities at different points in time.
Oh. Well, you know what? We have a community leaders meeting with our 12 communities this next month, and we will put this on the agenda to talk with the community leaders. So thank you.
Yeah, thank you very much.
Thank you. Okay. Oh, sure. Go ahead.
Hi, I'm Elaine from Monowese. We have been doing the red envelope and the SBAR communication form for over a year, along with our activities that we're able to do within the facility. And the problem that we're finding is that Yale does not scan in the information at the emergency unit area so that doctors on the floor have the information. Therefore, we're getting multiple phone calls from the hospital for W-10s, med lists, information that we've already sent multiple times to the hospital. Even days later, they're asking us for information.
You know what? That's a problem that's an internal problem they're well aware of and are working on. That's anyone in that process will tell you that somehow they haven't been scanning it, and sometimes actually they scan it into the EHR but misfile it. So that's been a problem too. So a doctor opens a tab that says W-10 and there's nothing in there, or there's an interact form in there. So yeah, I hear you loud and clear. That's you. You stay the course there, girl. The rest of us will catch up to you. But that's a problem they're very well aware of.
Hey, Sheila, it's Grace. Sheila?
Yeah, hey, Grace.
It's Grace, right? I just finally figured out how to get off mute. Thanks, Meredith. I'm from Yale New Haven Hospital. So, Sonica, I totally agree. We have had lots of problems with scanning that information. Kathy McKiernan, who maybe just came off mute as well, is working out a process with HIM and the emergency department. We're doing our own process mapping to figure out why those forms are not getting to the inpatient providers. It took me forever to get off the mute, but I wanted to speak up that we hear your concerns absolutely, and we are in the process of revamping that entire process of getting those forms to both to the ED providers and the inpatient. And then Meredith, in terms of the Yale New Haven Hospital using the W-10 for discharge out to the SNF, you're absolutely right that we don't use the SBAR format. We have all the elements of the W-10 incorporated into our paperwork, but it's not necessarily in a great format like the SBAR.
Okay. Great. Thank you so much, Dr. Jenks. We really appreciate that. So again, we will still put this on the agenda for next month for the community leaders, and we will report back to this group in August, on August 26th. I'm just being told I'm 3 minutes over, but that's okay. This is really important stuff. So thank you so much, Meredith and Grace and Monowese. Thank you for all this information. So let's talk about...
Before we move on, can I ask a question? Where do we order these transfer forms from?
All that stuff, you just go on the internet. You just go Interact, just type into Google Interact 2, and the website will pop up. You open it up. It will prompt you to indicate what you want. At the top will be a ribbon. You hit Tools, we'll give you a little disclaimer saying that you agree to use them as intended. You hit agree, and they're all there. You can just click on them and print them out.
Okay, thank you very much.
Also, if you decide that you don't want to print them yourself, there is another website. There's a link within the Interact 2 website that takes you. It's called Medline. Very similar name to Medline, and you can actually purchase packets of these documents if you care to. So again, you can always call us, and we can walk you through where these documents are housed.
Thank you.
Okay. You're welcome. Thank you. Great question. Okay, so finally, homework. Homework for session 6. So the team leader, prior to your next prior to your next meeting, the team leader, you need to make sure you have downloaded. The question was, where are these forms? You download the SBAR form, the nursing home transfer form, the QCare checklist from the Interact website, and make copies. And you're also going to download you're going to save these tools to one of your shared servers at your facility so other people can have access to them, because you don't want to be the holder of these. You want your team members to be able to download these tools if they need it. Also, the team leader is going to talk with your vendor of your facility to see if you can purchase red envelopes from them. Remember, Connecticut, we're doing the red envelopes for the emergency department, a separate envelope for EMS, and that could be a white envelope. But you want to make sure that you have two separate envelopes so both the emergency department and EMS gets the documentation that they need. Also, the team leader, you're not off the hook yet. You're going to look where your copiers are located, and you're going to bring this information to your next team meeting, because you want to make sure that as people are making copies, they're not running around the facility, that if you need to have one or two extra copiers around, you need to get to leadership and explain why it's so important, because that's part of the new process. And then you need to schedule 2 meetings with your team. One, the first meeting I'm going to review, and the second meeting is when you're going to map out your new process. So your first meeting, you're going to review the Interact tools with your team. You're going to discuss where the copiers should be, because you're going to bring that, as I said, you're bringing that information to your team, and then they're going to make recommendations, which you will then bring to your leadership about where your copiers as well as your supplies are located. And you're going to verify that, yes, your vendor can actually, you can buy the red envelopes and the white envelopes from them. If not, you're going to have to you can give us a call, and we'll give you a couple of links that we have for where you can buy the red envelopes. You also need to decide how the nurses of your unit are going to learn, who's going to educate them on, I know we've already talked about SBAR, but you might want to review it again, but also on the transfer form, and also about the red envelope. And finally, the second team meeting, also during part of this meeting, you should always be looking at your readmission data, and also if there's any issues about getting the data into your tracking tool. In that second meeting, this is where you're going to process out your current process for an acute care transfer. We're going to ask you to have at least 2 staff nurses part of this process, because they know exactly what's going on during an acute care transfer. So you're going to do that, leave that up on the wall for a couple of days, and have people react to it, and then you're going to map out your new process of where, using the new forms, having them making 2 copies, who's going to do who's going to actually create the red folder for you, because it takes 2 steps, the red folder, and then putting that acute care checklist on the front of that to make sure that it's ready to go. You're going to look at your capabilities list to make sure that it's up to date, and again, you can already put it in the red envelope, so that's one less thing you're going to have to worry about during the acute care transfer process. So this is a very important month to make sure that the process you put in place can go smoothly, and everyone is aware that everyone has a role, especially on the off shift. That nurse is not doing this transfer, or that supervisor is not doing this transfer by him or herself. It is a team effort. And again, I'm going way over. I'm getting pulled off by the hook. And always, whenever you start a new process, you want to make sure after the first one is done, you're going to debrief after it. How did it go? What went well and what didn't go well, and how can we fix it? And we want to hear about this next month. Any questions before we jump off? We want to thank you so much for staying on. I know it's 10 minutes after. This was a really important session. Great questions. And again, we're just a phone call away if anyone has any questions. And thank you so much. I'm thanking you from the Interact team. And we'll see you next month on the 26th. Bye, everyone.